I'm here to talk to you today about leveraging Primescan, the intraoral scanner, for delivery of screw-retained, digitally designed implant-supported restorations. And essentially, what I'd like to do is go through a workflow with you that includes not just the digital planning side of things and the digital scanning side of things, but also the incorporation of digital technologies, both at the implant and abutment level, to deliver what I believe to be the finest implant-supported restorations that I've been able to deliver in my 30 years of implant dentistry. And I think, all understand the importance of planning. So I'm going to share a case with you with missing molars. This is the upper right first and second molar, positions 2 and 3 or 1617, requiring a staged sinus lift. And today is not the day to be talking about sinus lifts, at least that's not my remit. So just to say that this was done on a staged basis. And this is now an acquisition image, acquisition video of the sinus graft, so that we can import this information into our digital Simplant workflow. And Simplant, of course, is a very, very powerful technology, those that are familiar with it. We see here 4 windows, 3 in the 3 axes, and 1 volume render. And we can work in the 2-dimensional sphere to establish things like panoramic curve. And we can work in the 3D volume render sphere to, for example, as I'm doing here, using the virtual tooth tool to establish the optimal position of where teeth should be. Now, of course, this might be guided by a radiographic template, or it might just be guided by one's own experience. But either way, the virtual tooth tool sets out the parameters back in the 2D images as to where we want to place our implants. So you see here now the implant placement tool. We're positioning the implant to optimally support the restorative goal. And in this particular case, you can see I'm specifying the implant as an Astra EV 4.8. So that color codes the implant according to the platform size. And we can then go ahead and look again at this in the 3D volume render and begin to appreciate that our sinus graft is well positioned to support these 2 implants so that they themselves can support the intended implant-supported crowns. Of course, we can use this information to produce a guide. It could be a pilot guide or a fully guided surgical guide that can be then taken to the mouth for surgery. Now, I don't have any images of the guide, unfortunately, but these 2 implants have been placed in a flapless approach using a pilot guide through punch incisions. So these 2 implants basically have been placed without raising any flaps, no incisions, no sutures, and this for the patient provides minimal trauma and minimal morbidity. One of the things that I feel is very much overlooked in the digital world is the fact that we should be using an implant that is specifically designed for these digital technologies. And right now, as far as I can see, there is only 1 implant on the market that has done that, which is the Astra Tech EV implant, because this is the only implant that offers you a 1 position only site-specific index, really designed for utilizing site-specific abutments, CAD/CAM abutments. It also means that in the Primescan technology, we can index this 1 specific position. As you can see, the inside of the implant here, the splines that engage with the abutment. So the scan flow is an asymmetrical 7-sided index in effect, which records this unique one position. Intraoral scanning, of course, has been a long-running saga in terms of technological development. And there are, of course, many options on the market for scanners. But it seems that we now have in Primescan a really state-of-the-art piece of equipment that provides phenomenal information with many tens of thousands of images captured per second at quite full depth, so that we're able to capture all of this information, including the bite registration, of course. And one of the reasons that I finally adopted intraoral scanners is that I actually had a patient, the patient that I'm taking you through now, who we were 90% of the way through an analog impression using infragum. I was just starting to put my hands in his mouth to unscrew the guide pins when he started gagging violently. And in fact, this individual, who's a big fella, became so aggressive that he pushed me out of the way, literally knocked me over, and in his panic gripped the impression tray and ripped it out of his mouth, ripping the tray off the impression copings, and in the process fracturing the core of a crown tooth on the opposite side. So the whole tooth came out, or the whole crown of the tooth came out in the impression. And he was, as you might appreciate, so distressed, as was I, that we agreed that we couldn't do another analog impression. And so this is what persuaded me to at least look into the Primescan. And in fact, this is the very first Primescan impression I ever took. And it's quite impressive, I have to say. It certainly blew me away. And it also blew the patient away for its quality and its clarity, both of the implants, the mucosa, and the dentition. And in fact, if you look on the contralateral side, you'll see here the upper left last standing molar has been fractured at root level. And that, I'm afraid, was the tooth that got ripped out with the analog impression. And again, these implants have been orientated using a one position only site-specific flow or scan flag. And so these can now be utilized in the digital arena to fabricate a unique site-specific abutment. We can also, of course, register the bite, and we get a really valuable map of the bite registration, giving us information on high spots and low spots, and of course, therefore allowing my technician to understand how he can build these implants into a protected occlusion, especially in a big patient with big masseters and a very heavy bite like this patient has. It allows us to take shade information, and whilst not necessarily 100% accurate, I have found this to be a very valuable guide to get me started in the process of shade taking. It's certainly a good starting point. The printed models, I have to say, have impressed me to the extent that they are dimensionally very accurate. I've worked for years with Natherstone, and although I've always been impressed with my technicians' abilities to provide me with crowns with good contact points and refined occlusion, the truth of the matter is that I've, since using the Primescan, had to do virtually minimal, if any, adjustments to the occlusion or the contact points on the crowns that have been fabricated on these printed models. So we are introducing a whole new level of dimensional accuracy. That information is then sent to Atlantis, and using the virtual abutment design software, you see here, we can start to fabricate abutments with different emergence profiles, different core sizes, core tapers, different margin positionings. In fact, today I'm pretty much routinely using the custom base abutments, which are screw retained. So the crowns are going to be bonded in the lab and the whole structure is going to be screw retained. And so these margins can actually be placed deep into the soft tissues because we're not having the issue of removing cement intraorally. And here you can see the two screw retained crowns placed in a protected occlusion, so there's slight clearance. And if we use the Atlantis reangulating screws, they happen to come with quite small screw heads. And so we can get very small holes through the ceramic or through the zirconia that we have here, which means they're very easy to mask. And to be honest, you wouldn't really know that there were any screw holes there. The transition zone from abutment to zirconia and layered porcelains, as you see here, is really very fine. And this means minimal irritation to the soft tissues. And certainly with a group of colleagues in Italy, we've published a couple of studies now, up to 4 years in function, where we're showing the most incredible biological and mechanical stability for these Atlantis abutments. And here you see in the mouth, it's impossible almost to see where the screw access holes are. And these provide really phenomenally high quality and biologically stable restorations. And then if we now take the final radiograph, we can very quickly see how that ties back into our original digital plan, placing everything exactly as was intended before we commenced with surgery. Here's another example that I want to share very quickly. This is a patient who during the first COVID lockdown, under the stress of it all, managed to fracture 2 premolars. And so her bicuspids, her second bicuspids, one each side, were removed, and we proceeded with immediate implant placement. And my personal preference is to use the direct abutment as a temporary abutment. And then we fabricate hand fabricated temporary crowns using shells chairside. And in fact, as you can see on the distal cervical margin of the upper left premolar, we can adjust the contour. So I've actually under contoured that crown. You see a small gap to the gingival margin. And this is to encourage the soft tissue to come down a bit there to give me a better scalloped architecture and perhaps a more defined distal papilla there. And here you can see the 2 implants placed very precisely to the floor of the sinuses with these temporary direct abutments in place. Some 3 months later, now in lockdown number 3, but thankfully we were allowed to stay open. She came back and we went through a Primescan, as we discussed before. And here are her 2 beautiful Primescan images. I have to say, patients love to see these images, and I think they might help to sell more dentistry in the long term, because they provide a phenomenally good opportunity to point out defects or deficiencies that may exist with existing restorations or with the patient's own teeth. Patients really appreciate being able to see their mouths in this way. And so I do think that these intraoral scanners may be a very valuable tool for encouraging patients to improve their mouths further. And again, this patient we took to the virtual abutment design for Atlantis custom base abutments. And the other thing to say is that in the laboratory, the technicians are also working in the digital world. So we're utilizing ExoCAD for digital articulation, and also to fabricate fully contoured or three-quarter contoured zirconia crowns that can then be layered on the buccal surfaces with porcelain, depending, I guess, on one's technician's preferences. And this really sort of completes the circle in terms of a digital workflow, because now the superstructures are themselves being milled from a digital design. And here we see the two crowns on their Atlantis custom base abutments. And in this case, we've got this gold hue, which is the titanium nitride color, the gold color, which gives a better shine through the soft tissues. And once again, we can establish these really superb emergence profiles. And there's virtually no ledge between where the crown meets the abutment margin. It's a perfect transition zone. And for me, undoubtedly, the soft tissue response is impeccable. It's often the case that we cannot probe between the soft tissues and these restorations. And if we can, we're struggling to get beyond 2 millimeters. So here we see the two crowns secured intra-orally. And initially we place a temporary wadding and we wait for 3 months, at which point we bring the patient back, check that the preload has not been lost before we finally place our permanent composite filling. I have to say I'm in the middle of another 2-year study with custom base abutments, and it is extremely rare to find that there is any loss of preload. These restorations are mechanically very stable. And here you see the finished radiographs, the final radiographs. And of course, the left radiograph gives me a fantastic opportunity to point out the importance of emergence profile, to use an implant that's specifically meant for a particular tooth size in terms of its diameter, to have an emergence profile of the abutment that is gentle so that there is a gradual contouring from the implant diameter through to the full contour of the implant-supported restoration. And if you compare that to the quite aggressive emergence profile on these two Straumann implants that have served the patient very well and were placed many years ago, but it's very clear to me that when we probe around implants with those kind of emergence profiles, we do get deep pockets, and we know that deep pockets mean anaerobic bacteria, and those bacteria ultimately can lead to problems such as mucositis or peri-implantitis. And to that very point, I would like to share with you a brand new study that has just been published in the Journal of Oral and Maxillofacial Implants, where I did a systematic review and meta-analysis to look at the marginal bone levels when comparing the surfaces of 3 premium brand implants, those being, of course, Astra, Nobel, and Straumann. Now, they have 3 very unique surfaces in terms of Tyenite, SLA or SL active, and osseous speed. And so I was curious to know, if we did a meta-analysis, would there be any difference in outcome? And so my null hypothesis was that they would all show a comparable marginal bone loss. In fact, I was very pleasantly surprised to discover that the Astra Tech implant with its osseous speed surface yields a statistically significant improvement in maintenance of marginal bone levels when compared to the other 2 implants. So I would refer you to this recently published study because I think it raises some important issues about the surface of the implant. That all said, I want to finish where I started and say to you that after 30 years of doing implant dentistry, I'm in absolutely no doubt that this digital workflow is delivering for me the finest implant-supported restorations that I've been able to provide my patients throughout that time. I hope it's been of value to you. I hope you've enjoyed listening. Thank you.